I stand before you today to present on this topic obesity, bariatric surgery, and renal transplant. I am Dr. Manjunath from AIMS Delhi. Obesity is abnormal or excess fat accumulation that presents with risk factors to health. There are two types, preclinical and clinical obesity, and all decided whether the patient is having or not having obesity related organ dysfunction or limitation to daily activities. What's important is where is the fat getting accumulated. As a central obesity versus the peripheral, the apple shaped deformity that we are able to see, this is more riskier as it harbors metabolic disorders. It's responsible for harboring metabolic disorders. New obesity definition sidelines the BMI and focuses on health. It does not mean that the BMI higher and higher threshold has been kept. Even at a lower threshold, if the central obesity or visceral deposition of fat occurs, that is a risk factor for metabolic disorder. Obesity is alteration in the function of tissue, organ, or system that is due to excess deposition of fat. It's most of the time idiopathic or multifactorial, also known as adiposity based chronic disease, and it is chronic, progressive, and recurrent or relapsing disease. Everybody knows how is the obesity and its complications occur. The fat gets deposited in each and every part of the body and affects everywhere, including the kidney. Today we are discussing on obesity and the CKD or the ESRD or the renal transplant. Obesity and its comorbidities have become a major global health challenges. Obesity in chronic kidney disease is found to be almost 50% in India. While it leads to the metabolic disorders like hypertension, insulin resistance, dyslipidemia, atherosclerosis, cardiovascular and cerebrovascular accidents. Obesity and kidney transplantation, though it gives a dialysis-free survival, but it comes out with worsening diabetes that increases the risk factor for cardiovascular, metabolic, and surgical complications. It is associated with rapid progression of CKD to end-stage renal disease. Bariatric surgery is safe in patients with chronic kidney disease. The literature that I am going to discuss further, it lowers the EGFR decline and even the progression to ESRD, improves the albuminuria, gives a long-lasting improvement from the comorbidities that the patient suffers with. It is considered to be safe and valid therapeutic option for CKD setting as of now. While post-renal transplant, there are very few case series and case reports which I will be discussing that gives a safety and feasibility, while the validation is yet to be done. Transplant recipients may develop obesity following surgery, that's transplant surgery, all owing to the glucocorticoids, immunosuppressants, and leptin. While glucocorticoid is responsible for insulin resistance, dyslipidemia, and abnormal glucose metabolism or hypertension. Tacrolimus is diabetogenic drug. Cyclosporine is hypertensive causing and increases cholesterol deposition. Anybody having BMI more than 30 is also, the studies have shown that the biopsy proven acute rejection, graft loss, and the development of diabetes, and even at the end the mortality is more with higher BMIs. It is associated, the obesity in CKDs are associated with enhanced comorbidities. As discussed, obesity related complications are well known. It is also leads to delayed graft function. Unfortunately, even now we do not have any optimal medical therapy for these patients, and post transplant exercise training are helpful but are not really effective. Currently, there are several case reports and series that suggest bariatric surgery after transplant is safe, feasible, and effective. Obesity following solid organ transplant and can be solved with bariatric surgery, though there are few consequences associated like post-operative infections in immunosuppressed patients. Most of the time, theoretically discussed facts like interference in absorption of immunosuppressants and nutritional supplement is no doubt one of the important required following bypass procedures. Impact of obesity CKD is well discussed. Before the transplant, there is long waiting list and access to the transplant can get delayed. A patient is harboring cardiovascular risk factor, the one which post transplant the patient one of the reason why the mortality occurs. Weight loss requirements have been explained to the patient, but it's difficult with medical or the lifestyle modification. Psychosocial factors are associated with that. Peri-transplant complications, as I discussed, the poor surgical outcomes, technical difficulties, longer duration, longer warm ischemia time, enhanced chance, the higher chance of wound infections, dehiscence, incisional hernia, delayed graft function. And following transplant, there are immunosuppression challenges, graft failure, delayed graft function, cardiovascular complications gets doubled, diabetes, which is like a poisonous disease, it tends, appears, dyslipidemia, psychosocial support, psychosocial problems occur, and lower survival rates. Traditional definition of BMI based has to be taken out, and more related to organ dysfunction, functional limitations, and quality of life has to be considered. That is more important. And very recently we have started doing surgery, that is metabolic surgery for diabetes less than 27.5 BMI. That is for the treatment of diabetes per se, and that is to prevent irreversible damage that occurs with long duration of diabetes or the comorbidities. So risk and balance has to be balanced. Surgery is simple but best treatment, gives a sustained weight loss, resolves the comorbidities, and gives a significant improvement in quality of life. This table says the BMI cutoffs are different when compared to the Western literature. For Asians, obesity is more than 27.5. 27.25 and above is obesity. Class 1 diabetes, class 1 obesity is 27.5, and uncontrolled diabetes becomes an indication for metabolic surgery, and class 3 is more than 37.5. These are all Western literature. When we compare, is minus 2.5. While waist circumference and waist hip ratio is important, with women more than 80 waist circumference and men more than 94 have increased risk. The Edmonton obesity system staging system is to discuss that the risk factors are more important, and the surgery should be more encouraged, not just as an obesity for weight loss, but also for treatment of comorbidities, which are very rarely and not seen with usage of newer medicines as well. So stage 0 is no apparent obesity, while stage 1 is borderline diabetes, hypertension, OSA, while stage 2 is risk factor diabetes, hypertension, well established and moderate limitations, while stage 3 is end organ damage established, and 4 is disability. The same thing which I have discussed in the past, BMI more than 27.5 with uncontrolled diabetes. Currently, we are offering surgery for them, and we have done 2 cases in recent last 3 months. BMI between 30 and 34, there is increased risk of delayed graft function, acute rejection, post-transplant diabetes, and wound complications. The studies have shown that the high incidence of diabetes occurs post-transplant at the end of 5 years. So the patients will have been explained about the lifestyle modifications, diet and exercise, which frequently tend to fail the traditional methods, and surgical intervention should be considered as a viable option. 32.5 BMI and above are relative contraindications for transplants. They have limited access for transplants. There are technical challenges, and obesity patients have 2 to 3 times more possibility of developing vein and arterial thrombosis. It is about 12% of patients who come for the transplant do have BMI more than 35. High subcutaneous and visceral fat is associated with technical difficulties, which I have discussed. So more than 35 comorbidity patients should be referred for surgery. Before transplant, I would say, is always better than the after transplant, because after transplant we do not have so much of studies which could support our evidence. Choice of surgery, decrease in BMI, and resolution of comorbidities gives a better long-term graft survival. Bariatric surgery is most effective. Sleeve gastrectomy is preferred surgery, while Roux-en-Y is coming up with promising results as it resolves many of the comorbidities. This moderate perioperative risk, which should be acceptable, as the outcomes are better than the risk. Albuminuria is better resolved with the surgeries. More than 50% of patients with end-stage related disease are able to get listed within 5 years. MBS, that is metabolic surgery, is shown to be safe and effective to bridge liver transplant. There are studies which have shown 3-fold higher probability of heart transplant undergoing, safe and effective in heart failures. In related to that, there's a limited data with obesity and stage lung disease. The pros and cons of the Roux-en-Y or the bypass is well known. While sleeve gastrectomy has its limitations of weight regain and re-emergence of metabolic syndromes, there is necessity of multidisciplinary team approach in these surgeries. These are the port positions, and we have done around for the potential donors 2 sleeve gastrectomies. 3 patients who came with ESRD, we have done sleeve gastrectomy. These are prior to the transplants. While 10 cases we have done, most of them were the bypass for CKD less than 3B. These are the port positions. These are the 4 ports. This is supraumbilical, and this is the mid-clavicular line in the right hypochondrium, and this is the right hypochondrium, 5 mm each. So I would like to show the surgical step. This is the greater omentum is released, is separated from the greater curvature, and sleeve is created over 38 bougie, and then following this leak test is performed. That completes the surgery. And this is the bypass surgery, where a window is being created in the lesser curvature. A stapler is fired, and a small pouch about less than 100 ml is being created over the bougie of 38 French. The length of the bowel, that is biliopancreatic limb length, is measured depending on the BMI of the patient and the comorbidities, the duration of comorbidities, and C-peptide levels. Stapler is fired and anastomosis is completed. This is single anastomosis mini gastric bypass that we tend to do for the patients. Now, post-renal transplant obesity, there are quite few studies, with the largest meta-analysis which shows 30-day mortality is significantly less. No preoperative or serious post-operative complications were documented by Eli et al. These are all the post-transplant surgeries done. 45% reduction in excess weight loss, which is not seen with the available medicines, remission of comorbidities, and significant weight loss or obesity-related comorbidities has been documented. The no post-operative complications and no alteration in the dosage of immunosuppressants has also been documented, but all these studies are quite few. There are studies which have been done, surgeries have been done even after the liver transplant. Laparoscopic gastric band was done in pancreas transplant patients because the bypass is generally not done. The bariatric bypass surgery is generally not done following pancreas transplant surgery. Similarly, the lung transplant, high reported rates of post-operative reflexes, and hence RYGB, the Roux-en-Y gastric bypass is preferred. The impact of malabsorption of drugs, immunosuppressants, was documented in olden literature, that is 1996 and 2008. However, the same thing has not been noted in the recent studies. There are several studies which have shown that there is no relation of immunosuppressant absorption issues related following the surgery, bypass surgery in post-transplant patients. So, last 2 minutes, sure. Two more slides. To conclude, consensus, what I would like to suggest is the consensus about the definition of obesity and BMI cutoffs for renal transplants and ESRD or the CKD has to be done. They have less excess, increased waitlist time, and often they are advised to lose weight by medical treatment, which traditionally are being advised, but they tend to fail. Graft outcomes and usual cases of higher BMI, with a higher BMI, the graft outcomes are poor. Earliest intervention for weight loss has to be encouraged. Bariatric surgery is safe, feasible, and effective treatment for resolution of, especially for resolution of comorbidities. And bariatric surgery post-renal transplant needs further validation that can occur with only with larger available data. Thank you.
Thank you.